Welcome to everyone who is here. We're really excited to be hosting this webinar today by the Palliative Care Committee. And the topic we're going to be covering is called Pathways to Palliative Care, Opportunities for EM Physicians, Career Opportunities for EM Physicians. So tonight's program is recorded and we're going to upload it to our AAEM website and also share it on social media. So if you weren't able to be here live or you want to look back at it in the future, it will be there. And if you're in the audience, feel free to say hello in the chat. When you registered, there was an opportunity to submit questions. And so we got a ton of questions from you all. Thank you so much for sending those in. That helped us plan what we're going to talk about today. And it is going to be in a Q&A format. So you all submitted questions and our wonderful panelists also submitted some questions that they wanted to cover. So that's what we'll be using today. If there are things that we don't talk about, feel free to put them in the chat. I and our panelists will also try to keep an eye on the chat and answer them either in the chat or we'll talk about them aloud, especially towards the end if we've got extra time. I guess I should have started by introducing myself. I apologize. I'm Maggie Putman. I am the chair of the Palliative Care Committee. I am an emergency medicine and palliative medicine physician. I did emergency medicine for 9 years before going back for a mid-career fellowship. So I'm going to be moderating today. And now I'm going to have our panelists introduce themselves. And I'm going to stop sharing my screen so you can see our faces. Okay. So first, I'm going to ask Dr. Jessica Fleischer-Black to introduce herself, and she's our immediate past chair of this committee.
Hi, everyone, and thanks, Maggie. So my name's Jessica Fleischer-Black. I'm in New York. I trained at Bellevue in emergency medicine and worked in emergency medicine for about 20 years or so. And then by that point was at Mount Sinai. And while I was at Mount Sinai, Beth Israel, I wanted to do a palliative fellowship and found a way to do it while still working. So it was a part-time competency-based non-time-based fellowship that I did in 2020-ish to 2022. And then now I actually have switched over to being full-time Pal Care inpatient at Forest Hills Hospital in Queens.
Thank you, Jessica. Next, I'm going to go to Dr. Bruce Gutierrez, who is the vice chair of this committee.
Hey everyone, so I'm Bruce Gutierrez. I'm actually a recent grad. I did my emergency medicine residency at Jacobi Montefiore, and then I did a palliative care fellowship directly out of residency at Mount Sinai. Fortunately, I'm now officially board certified in both. Currently, I do a split hybrid role at New York Presbyterian Weill Cornell in New York City. I spend 80% of my time in the emergency department and 20% in the palliative care inpatient consult service. And that looks like about 9 weeks of palliative care per academic year. So my primary appointment is in emergency medicine. So even though when I'm on pal care, I still bill to EM. So it's a fun little.
Thanks, Bruce. Next, I'm going to go to Dr. Melanie Ulrich.
Hi, everyone. I'm also a recent grad. I did my emergency medicine residency at LSU in New Orleans from 2019 to 2023. Yep. And then I went straight to hospice and palliative medicine fellowship at University of Wisconsin in Madison. And I graduated last year. I am currently doing UW is a program that offers an extra year in medical education fellowship. So kind of like what some EM residents do in terms of like non-ACGME medical education fellowship. I'm doing that, but on the palliative care side of things. And so I'm the attending on our palliative care inpatient consult and unit 5 weeks of the year, and then the rest of my time is working on projects. I plan to do a full-time inpatient palliative care position out east starting in August. So looking forward to talking with y'all.
Screen is Dr. Jason Bowman.
Hey everyone, my name is Jason Bowman. I did my 4-year emergency medicine residency and chief resident year, clinical palliative care fellowship, and then a research fellowship in the Harvard system. Stuck around for a couple of years as a dual board attending and practiced both roles. Was 50% emergency medicine, 30% palliative care and 20% research. And then followed my wife with the dog and our daughter down to Houston. I practice at Baylor now, and I do 40% emergency medicine, and then just got a K-12, so sort of adjusting my time as I go. But yeah, happy to answer questions. Glad to be part of the panel. If folks want, happy to also talk after the session. I think we all are, and we'll talk about that in a bit. But I think a couple things that may not come up in questions, but I had some experience with a terminally ill loved one when I was a trainee in a junior faculty. So if that fits with anyone who's on the call, happy to talk offline and support however I can. Thinking about splitting your time, something I've done now at a couple of sites, so happy to talk about that. And then also, if you're interested in research and wondering how to do 2 clinical jobs and research, I'm happy to talk about that too. But glad to be here. Thanks.
Jason. Next is Dr. Darren Agresti.
Hi, everyone. I'm Darren Agresti. I did my med school at NICOM, the DO program in Long Island. And then I did my residency at St. Luke's Hospital in Bethlehem, Pennsylvania, which is on the eastern side of Pennsylvania. I've been a clinical doc for 10 years, and then I switched over to more of an academic / clinical doc role now at one of our sister campuses. I am not palliative care hospice trained. I am the hardworking emergency medicine doc who still believes that a lot of palliative and hospice medicine should start in the emergency department and hand off to our amazing colleagues here thereafter. But it's always been a passion of mine, so I'm happy to be a part of this committee as well.
Great, thank you. Next, I'm going to Dr. Alexa Gale.
Hi, everyone. My name is Alexa Gale. I went to med school in the Royal College of Surgeons in Ireland, and then I came to this back home, and then I did a residency at Robert Wood Johnson in New Jersey. I practiced for about 10 years, and then I tried to do what Jessica did, was do a mid-career fellowship, but that COVID hit, so it really wasn't going with the flow at the time. So I took a break from EM and took a year off there to do fellowship. Recently, 2023 is when I graduated at GW. There were 4 of us. 2 of us were EM physicians. We had an EM faculty member who was palliative trained as well. And now double boarded. So I don't do a split role. I try to do 1 to 2 shifts per ER per month, but I work fully remotely. So I'm doing sort of a palliative care role remotely. Would happily talk to you guys about that and what that entails. Also, like Jason, when I was an attending, I had a family member who was quite ill and actually was the reason for this sort of impetus for this journey. So happy to talk to you guys about that. I tried to do a poster for AHPM about how to help providers who are taking care of clinically ill patients that are their own family members and how to support them, but unfortunately was not accepted. So, but happy to talk offline.
Thanks, Alexa. All right, Dr. Barry Diner.
Hi, everyone. So I am not a new grad. I'm a PGY 29 actually this year, and still going strong in the emergency department, pretty much full time. And then I didn't do the fellowship, but I am boarded in hospice and palliative care, and that's because I grandfathered in 2012, and I'm actually in the midst of recertifying now on a continuous basis. And I do only home hospice. So I don't do any inpatient. I don't do any consults in the hospital. I work separately in the private sector for 2 different hospice companies as a medical director or team physician. And I'm happy to talk to people about that. So I actually practice, I wouldn't say full-time in both, but pretty close to full-time in both.
Thank you. All right, Dr. Tara Shapiro.
Hi, I'm one of the more seasoned physicians also. I completed a 4-year emergency medicine residency and then worked clinically full-time as an EM doctor for 22 years and decided in 2019 to go back and do a fellowship. And I did it at Jamaica Hospital in Queens, right when the pandemic hit, and was very grateful for that experience. And I have never been drawn back into the emergency department. My heart and whole career has now been in palliative care. I worked full-time for 3 years after my fellowship at Montefiore in the Bronx, and now I work in my hometown part-time at Nyack Montefiore and love it. And glad to talk to you about being a part-time or full-time PalCare doctor.
Thank you. All right, finally, Dr. Mari Siegel.
Hi, sorry, I'm old, so I had some tech issues in the beginning. I also just finished an ER shift, so I had grand plans to like change and show all of the youngsters that like you could do it all and like look great and have an outfit on. Yeah, I'm in scrubs and whatever. I'm also cooking dinner for my kids simultaneously while my child has Hebrew school tutoring, and so what we do as ER docs. I also am one of the older folks. I had a fairly untraditional path. I did an internal medicine residency, realized that I was not one of them. Went through the match to do an EM residency, was a hospitalist in between, had a ton of end of life experience, like care for patients throughout my 2 residencies and time as a hospitalist, and really felt like something was missing from EM for me. Really loved it's weird to say, but you all understand, loved my end of life conversations with patients. In the ER, I wasn't able to form those connections the way that I did when I was on the inpatient side. So, like Barry, I believe I also took the boards in 2012. So I was doing this anyways. I was just working at a hospice, and then became aware that, I can actually sit for boards. So I did that in 2012. I think my experience is a bit different than most people's. I kind of had to claw my way into a dual position. Took about 8 to 10 years. I did it for free for a while, just because I wanted to keep my skills up and I love the work. And so for a while I was full-time EM or 80% EM, whenever with kids, I've gone back and forth from 75 to 50 to 100, whatever. I spent like 6 years just kind of working with the PalCare team because I wanted to. And then got a position there eventually.
Let's start organizing that.
Got a position there, and then for a few years was actually the medical director for PalCare. I am now back in EM majority of the time, just because life happens in palliative care. I will say it's weird being 8 to 5 or 7 to 6 or whatever. And my life right now needs me to have flexibility. So I'm currently back in EM, but what's amazing about what we do is you can go back and forth. I'm happy to talk offline about the challenges of both roles, because they both have incredible advantages and they're both wonderful. But there's also challenges to balancing your life in either role. But yeah, I love palliative care. My role is primarily educating EM physicians on, primary palliative care, and the rapid goals of care conversation, and incredibly happy to see the growth of this group from a couple people to closing in on 100, and the future looks great. So.
Thanks, Mari. All right, so as you guys can already tell, we've got a lot of different pathways that everyone took to get to where we're at and the way we're practicing. So my first question is for Jessica. Can you talk to us about how you managed to get a part-time competency-based fellowship, and how could others maybe do the same, and where else is this being done besides Mount Sinai? You're on mute.
Unmuting. Yeah, so I was incredibly lucky. So basically I was like, doing emergency medicine, working full time, being the primary breadwinner at home, had kids, had a mortgage, had a husband, all these things. And, I wanted to do a palliative fellowship. I did, but I did not want to take this huge financial hit that I was going to have to take for, it's only a year, but like it's a year, and I felt bad. And I happened upon an article in I can't even remember whose whose newsletter, about a program they were doing at Penn that was this competency-based part-time fellowship, so that people could keep their initial positions and kind of like get the PalCare training they needed, and stay within the institution. So I read about it. I asked my mentor at where I was working with Mount Sinai Beth Israel, and he said, I don't know, you should just like ask them. So I asked them, I was like, can we do this here? And he was like, I don't know, ask the Penn people. And I asked, and they were like, oh yeah, we've actually been looking for a second place to try it. And so I contacted the Sinai people, they were into it. It all just like fell into place really incredibly fortunately. And my chair was into it. They were like, sure, we'll give you time off to do it. It just worked out super amazing. And I got this great education and I was super lucky. And they were pretty happy with how it went. And they've actually had a competency-based fellow ever since. So they keep like one slot open for that. They've had surgeons, they've had anesthesiologists, they've had all sorts of different people. And then a couple of other places have been doing it as well, which I think includes like University of Minnesota, I think WashU, Penn, I think Harvard. Jason, you'll remind me if that's true. It is true.
Yep.
I think it's true.
And also UCSF, Emory, and Chicago.
Yeah. So, and then, now I also realize that there are some other places that just kind of do it a little sneaky, like it's not competency based, but it is part-time, like North Shore in Long Island, they often divide up a spot between two people. So like if you find an EM buddy, maybe you could split a spot at a local place. So that might be a way to figure it out. The way I did it, Sinai just kind of took the hit of losing me in one role and losing like whatever my RVUs or whatever it is in the ED. But other people have filled that sort of financial void with a grant, or they've just actually they've done it for free. They've done the fellowship for free essentially and taken, 20% pay cut. People have done it different ways, but I was super lucky that I was able to do it. But you could be lucky too, you out there. Maggie, you're muted now.
Can you hear me?
Yeah.
Oh, okay. Thanks, guys. Sorry. Okay. Some of you guys talked about this as you were giving your introductions, but I think it's helpful to hear more about why people made these transitions. So I was going to start with Melanie. What inspired you to transition from EM to HPM, especially so early in your career?
Yeah, so a lot of my stories come from like rotations in residency since I went straight from residency to fellowship. And I didn't even really know that palliative medicine was a field in itself in med school. I don't think my med school did a lot of teaching of it. I'm excited to see that that's growing now. But so I really learned about it while I was on my MICU rotations in residency. And I was definitely drawn to those like complicated cases where, decisions needed to be made and family members were all over the place and just needing to be able to like come in and learn about families and learn about the patients that we were caring for and what was important to them to guide their decisions. And of course, I got some of that experience by like sitting in with palliative care teams while they were meeting with patients and families. But a lot of this was done on my own time at like 5 or 8 p.m. at night, as the clinical day as a MICU resident gets away from you. And this was like OG COVID era. So it was like that was just when I could call families. So to learn that palliative care exists and to be able to make that into my full-time job, I was just so fascinated. So I had to explore more. So it's kind of like my origin story. But at the same time, as I was learning more about it on the MICU, when I would go back to the emergency department, and I did a 4-year residency, so it was a little bit through the years, I was kind of starting to feel more and more like a cog in the wheel in the emergency department, or kind of like just putting band-aids on dams that were breaking left and right. And of course, I'll name, and this probably resonates with a lot of people, but that's more like the healthcare system making it feel that way than EM itself being built that way. But I was personally having a tough time trying to figure out if this was like senioritis, every 3rd and 4th year resident feels this way, or if this is something that would get better as an attending. But I had already fallen in love with palliative care to like explored that as a fellowship. And so I went straight to fellowship to learn more. And I learned about myself that that feeling I was having in my third and fourth year was really kind of me falling out of love with emergency medicine, to put it lightly. And I know that won't be the case for everyone here, so I might be alone in that. But I was that like stock card pre-med student who went to med school to like help the most vulnerable patients, and EM certainly filled that purpose for me for a little while. But I've found that palliative care fulfills that way more for me personally. Again, this is very personal. But it just created that on a whole nother level. I had a lot of turmoil in terms of like giving up something that I spent so much time training in. But I had a mentor tell me that if you're missing like the undifferentiated patient aspect of emergency medicine, then maybe moonlight or go back or try to see like if that's something that you're missing. But for me personally, I just didn't miss it in fellowship. And so we get some undifferentiated patients with like our symptom management side of the job. So I think that fulfills it for me. And you guys will hear from multiple people who are still in love and doing it both things. So this is just one story of many. Hopefully it's helpful, and I'm happy to talk more about any of that offline.
Thanks, Melanie. Do any of the other panelists want to speak about this? I know Tara, I think one of the things you had mentioned was, why you transitioned instead of doing a split role.
I'm gonna go to her. I just wanted to add that there's nothing wrong with any of the feelings expressed just now. Everyone goes through phases, or they're permanent, but whatever you're feeling, like that's just where you're at. And it is totally okay to not love your first choice. And it's totally okay to never come back to your first choice. And it's also okay to ebb and flow. So I'm going to mute again.
Thank you for your wisdom, honestly.
Yeah, so echoing kind of what Melanie was talking about, my journey came from multiple factors and was for a very long time. I struggled for probably 10 years before I took that jump and went into fellowship. And a lot of my wanting to do that was from personal experiences with death in my own family that were done well and that were done very poorly. And then also just seeing like that cog in the wheel feeling that I was having of, people would just be like, just throw that central line into that old lady from the nursing home and admit her to the ICU. Like that's a slam dunk, easy. I felt like I couldn't sleep at night anymore. I felt like I was not really finding out what patients valued. Did she want me to do that to her? Where was her voice? Who was speaking for her? And I just felt as though I was being pulled towards palliative care. I loved my emergency medicine career. It was wonderful. It was fun. It was interesting. It was frustrating. It was everything that I thought it would be. But towards the end of it, there were certainly signs by the universe of shoving me towards palliative care. And I had all of these feelings of, can I really do this? Is this going to grab a piece of my heart every single time I'm talking about death and dying every day? And will I have the emotional strength to do that? Will I be able to be present in a room full of people who are grieving and not be pulled into that myself? How will that affect my relationships outside of my job as a palliative care physician and my family? And then the financial aspect too, right? Because palliative care doesn't make as much money as emergency medicine does. We don't do really hardly any procedures, although there are opportunities to do them, especially in the home hospice arena. And so, but we certainly don't make as much. And so that was a consideration. And finally, my husband shoved me on Valentine's Day in 2019 to make that leap outside of the match. And I luckily got into a program, and I have never regretted my decision. I walked through the ER and I remember being there and things, but I just don't feel any pull to want to be there. Where I'm at now is where I'm supposed to be, and I'm really very fulfilled.
Thanks, Tara. And you brought up the financial aspect of it, and quite a few of the people that registered for this webinar wanted to know more about compensation. And I'm wondering if any of our panelists feel comfortable talking a little bit more specifically about their compensation in hospice or palliative compared to emergency medicine.
Can't really hear you that well.
Oh,
there you
sorry.
go. That's better.
Okay. Thank you for letting me know. Yeah, so I was just saying that a lot of the people that registered to attend this webinar wanted to know more about the compensation. And so I was wondering if any of our panelists feel comfortable talking a little bit more specifically about the difference in compensation between palliative or hospice and emergency medicine.
I could talk on with regards to home hospice and how payment is usually done for doctors. And this is usually doctors who take our team physician, they call it. So part of the home hospice is that you need a doctor, a nurse, clergy, and social worker at the minimum for each team. And so they need a doctor who's available throughout the day, and then sometimes, depending on how big the team is, weekends and nights. And so generally speaking, the pay is usually about, if you're just going to do the call during the week for your team and do a team meeting, let's call it every other week, is probably about somewhere between $3,000 and $4,000 a month. And then if you're going to do call on the weekends, that's somewhere between $750 and $1,000. And then if you're going to do nights, it's somewhere about $750 also. So it adds up pretty well. You do call, there's no expectation that you're ever going to see a patient or go in to see the patient, unless you'd like to, but there's no expectation that you'll ever do that. And so it's the ability to kind of do that and do something else at the same time. And you can do it from anywhere you want for the most part, except for your team meetings. Sometimes you have to be in person. So you could do decently okay. And then if you do home procedures, which I do, that's that you have to negotiate on your own. But offline, I can tell people what they can do and how much they can get, or how much I get paid for it. I'm happy to share. But I do all kinds of procedures at home, and I'm compensated fairly well for that.
Thanks, Barry. Outside of compensation, can you talk about what your job is like doing home hospice and how you put your ER twist on it?
Yeah. So I don't know if I'm the only one who does it, but I haven't found anyone else who does this. So I do home procedures on patients in our group, and I do home paracentesis. I do trach changes. I do peg changes. I haven't yet done a thoracentesis, but I would. I just haven't. They haven't asked me to do it. I do, if a patient falls and I'm available, I can run out and suture someone or glue them. I've done that too. So just a quick story. And I thought that this is like emergency medicine to the max. One of the first times I'm doing a trach change and they asked me to go see a patient. So I drive there and I arrive at the scene and it's a feed store, and I'm in Houston, and it's a feed store. And I'm like, geez, I call the office. I'm like, you sure you got the address right? Because this is a feed store for animals. And they said, yes. So I walked in and I said, I'm Dr. Diner. And they said, that's fine. The patient's in the back. And I was like, okay. And the story is this guy owned a feed store his whole life, and he was dying of esophageal cancer. I think it was esophageal. And his son was running the store. They cleaned out the back. It really wasn't clean, but they cleaned out the back of the store for him so that the son could take care of him during the day. And he would stay there at nighttime with him. So it was not unreasonable. This is the way they made a living. And so I went to go change the trach. So I walked into the back of the feed store, and I'm going to change the trach, and I have the new Shiley with me. And then I realized this is the first time I'm doing it outside of a hospital. I got no suction. I got no NG tube. I got no Shiley. I got nothing. And I'm like, this could be really bad really quickly. So I'm like, I'm just going to do it, which is really a stupid thing to do. In the meantime, since then, I've put together my own kit that I have like a knife, and I have like small ET tubes, and I have so if I had to create an airway afterwards, I could. But anyways, I took it out, put it in, it went fine. I put him back on his trilogy, and he was good to go. Anyways, that was like an interesting story that I'll always tell in the back of a feed store, which was crazy.
So you're the family medicine doc of hospice care.
The emergency doc of hospice care, because I know the family doctors would not do that. There's like no.
You're a rural family med doc. I don't know. You're awesome.
Yeah, maybe old school family med, you're right. But anyways, it was an interesting experience. So that's the way I've really been able to. And I'll tell you something, it's really expensive to send someone from home to the hospital or an outpatient center to get a paracentesis. It takes half a day. They require blood work. They do it under ultrasound guided. For all us old school people, they didn't give me an ultrasound. I still don't have an ultrasound. I roll them on their side. I percuss it like old school. I go low and low, meaning low, low, and low. And I take off tops 4, maybe 5 liters of fluid, and I call it a day. And I move on. And the patients love it. I get hugs all the time. You made me feel better right there. They're gracious. It takes 20 minutes, maybe 30. You're in and out if you want to be. Talk to them. You have 30 minutes to talk to them. You're just changing bottles. And by the way,
Barry,
and for the ID people, you don't have to discard the fluid in disposable, like the red bags for that, because it's their own bodily fluid. You could just throw it into the garbage. Interestingly enough.
wow.
I didn't know
So
that.
Barry, I've always thought that this is such a niche part of medicine that emergency physicians fill so great, right?
Yes.
We develop relationships very quickly. We're highly trained and skilled in all of these invasive procedures, and we could really, frankly, do them anywhere.
Yeah.
And so I really think that as a group, we could push this to a national scale.
And
It
Barry,
took me a year to get permission, like to convince my hospice that this is like an okay thing to do.
and
So-
I'll just second that. So before I took the role that I have now, which is totally remote, I was signed up to be the IPU director for a local hospice in the DC metro area for the sole purpose that they wanted in their IPU a physician that could do procedures. So instead of sending them to their, to the wherever they would get their paracentesis, it would be even cheaper if they could just get them to come to the IPU. They would have left one of the rooms open, and then I would have done the paracentesis, the trach changes. I don't know if they would have wanted me to do a thora, but I can attest that that's the reason that they recruited me and wanted me to be hired, was to do that solely. Unfortunately, it didn't work out because I got another opportunity that worked better for my life. So, but the skill set we have as emergency room physicians, and that's why I still do shifts to keep that skill set, since I don't actually work totally clinically in my role. I still do it just for that reason, to keep that skill set up, because there's something about it. Like one day I might not want to do this. I might want to do inpatient hospice, or I want to do hospice like Barry's doing and be able to use those procedure skills that I trained and used for over 10 years. So, and Barry's right. Like, patients are so happy. They're just so grateful when we can do something so simple like that.
And Barry, there are a couple questions in the chat about, one, what does the malpractice insurance look like for you for doing procedures? And is there a credentialing, like how do you get credentialed to do
Right.
those kind of
So
procedures?
when you do home hospice, the 2 home hospices that I work for, and I've worked for 3 in my career, they all cover, I don't have my own malpractice, so they cover me with their malpractice. And in terms of credentialing, they never asked me for my log. I'm like, I just do this. I know how to do it. I mean, I guess I could have gotten a log from the hospital, but at this point, yeah, no one questions that. I don't know. No one's really said, I said, yeah, I can do these things. They're like, yeah. No one said, could you change a trach? I'm like, yeah, I can change a trach. Like, and if not, I'll figure it out. Like, it's not rocket scientist work. And so it's just a matter of like, again, I have this kit in the back of my car now, really, with a bougie and a blade and a couple of like, a 5/0 tube, a 4/0 tube. I'm like, go small and then call 911 and scream help. And like, I have a bag. I took everything from the hospital. Like, I'm like, I'll take something from here. I'll take something from here.
Yeah, who covers the cost of those, all your supplies?
So no, so that I got the hospice, like I have people, like just they have, home hospice does a lot of supply with McKesson and stuff like that. So I made it clear what I needed, and I just tell the person, I'm like, I'm running out of bottles, and they're like, okay, I'll order 3 more cases of it, or I'll order the paracentesis trays. And trachs and pegs, you need to find the one they have to order it. So it's a little bit trickier. But if you know that it's coming up, then you can do it.
I think, just to interject, as someone who has to sign off, so every year I have to sign procedure attestations because medicine and EM can't. So anyhow, it's annoying. If it really depends on where you work. If you're in a system where EM, like we don't have to do ATLS and ACLS and B, right? So every year I have to remind my medicine people that I don't have to do this, and then they're fine. And your credentials from residency, you don't necessarily have to have them if so ABEM's website says, based on completing a residency, you're competent and approved to do this number of things. So if you're in an academic setting, which is, I think, different than what Barry's doing, you're fine with what you've done in EM, because we do thoracentesis and paracentesis and all that. I can't speak to the more to the approach in rural and non-academic stuff. But if you're staying in academics, what you do in EM will definitely be enough for you to be able to do procedures with the inpatient, at least, palliative care, and anything associated with that.
Thank you, guys. I want to just take a little shift over to talk to Darren a little bit. You're doing full-time emergency medicine, so can you talk to us about how you're incorporating palliative care into your EM practice?
Yeah, absolutely. So I absolutely love, my palliative care colleagues here, but at the same time, I still do strongly feel that a lot of emergency medicine, hospice and palliative care should be a huge part of what we do as well. At least where I practice, we have a large nursing home population by us. I've been out of residency for 13 years now, but I distinctly remember about a year into my first year as an attending, I had a patient from a nursing home who came in horribly, uroseptic, and I intubated her and put a central line in her and was all proud of myself that I got to do all those things and thought I did everything correctly. And then I remember the family member walking in and just looking at her mother and just saying, like, she never would have wanted any of this. And it like punched me in the gut. The patient had no paperwork with her. Nursing home sent nothing. I remember we called over and it was that classic, shift change. I don't know her stuff, how they can't look it up immediately for me. I don't know, but nobody knew anything about her. And that case just always stuck with me. And I really made it it's always been a passion of mine, palliative hospice medicine. But from that point forward, I really always made it a point to, before I do just about anything, I really always make a point to make sure that this is what the patient would want. And I really go out of my way to. In emergency medicine, we really get pushed to look at our RVU numbers and our Press Ganey numbers and our patients per hour. And I would just employ anybody out there who wants to stay EM to just have that in the back of your head, that you could still have a career in emergency medicine and practice some palliative and hospice medicine by putting all those metrics aside and just taking that 20-minute conversation with the patient's family and with the patient, obviously, if they're coherent enough, and forget your metrics for that period of time and do the right thing. No, I incorporate it all the time. I see some of my colleagues will admit patients just for a simple paracentesis or for a thoracentesis, so IR can do it in the morning because they just don't want to do it. And I just am really disagree with that. This is a lot of times end of life patients who don't have a ton of time left, and the last thing what they want to do is spend another day in a hospital to do a procedure that you yourself could do in the emergency department. So I think the average ER clinical doctor can practice a lot of these, or not practice, but incorporate a lot of the skills from these types of fellowships into their regular practice and still just be a full-time ER doc.
And Darren, can you tell me, I know this wasn't a specific thing, but I'm just wondering, because a lot of ER docs that are busy on their regular EM shift, they feel like they don't have the time. How did you kind of hone your serious illness communication skills to feel like you can incorporate these conversations, these goals of care conversations, in a way that's effective but doesn't derail your shift?
Yeah, no, absolutely. So, I'm sure everyone on this panel has their lines and their skills that they typically use with people. But I remember as an intern, one of the palliative care docs who I rotated, he was in the ICU with us, and I remember sitting in on a family conversation with him and them, and he basically, summing it up extremely short, essentially said, if take the 30-year-old version of your mother and have her standing in front of us right now, let that voice be the loudest voice in the room. Like, essentially, what would she want? And that was a probably 5 or 10 minute conversation. I'm completely paraphrasing down. And so many families, they just want a doctor to basically say, like, it's okay to essentially just control pain and to ease suffering and just to allow them to go peacefully and naturally. That's what most people want. So I actually don't find it takes a lot of time. What I find more than anything is just a lot of doctors just shy away from it because they're uncomfortable with it. And I'm not sure I could really answer how or why I am comfortable with it. I guess I just kind of always have been. I always just found from a young age, like, it's just part of life. It's part of our process. And it's very easy to throw that central line in and put them up on the floor, just like we were saying earlier, Tara saying that earlier. It's so easy to do that. What I find, it's harder for a lot of doctors to just sit down and have that conversation. And again, I know I'm preaching to the choir here, but I feel very passionately that it's just a very important part of our job that unfortunately is being pushed aside.
Thank you. I want to go to Bruce and Jason. You guys are both doing splits, like current splits in one institution where you're doing some EM and some Pal Care. So I'm just wondering if maybe start with Bruce and then Jason, if you guys can each talk about what it's like working in both those roles and how you juggle that.
Yeah, so I think for me, I really appreciate the variety of clinical work that I get to do by splitting my time between the emergency department and then a palliative care service. And I do find that a lot of the work I do in one department complements the work I do in the other department pretty well. Oftentimes I admit patients from the ED and see them later on, and as a consult while they're on the inpatient side. So I do get to see that continuity. That's pretty rare. And I think one of the things that I contribute to both departments is I do provide a unique perspective, being both an emergency physician and a palliative care physician, because I know that sometimes there can be a little bit of tension between the two departments, especially when there's consults that are coming in, and one feels that it's not an appropriate consult versus the other sort of feels like this is something that they can handle, and vice versa. So I think I do serve a role in just sort of smoothing out some of those relationships. And yeah, I think I think there's people always ask me, like, oh, which do I prefer more? Being one or the other, and I've actually have been struggling with this with that question, because I think there are things that I love about both specialties, and also things I don't love about both specialties. And there's pros and cons to both. And I think right now just having being able to do both sort of balance out the negatives of the other, if that makes sense. So I'm pretty grateful to kind of have that opportunity.
Thank you. How about Jason?
Yeah, echo everything that Bruce said. I think for me too, as a resident, I did a rotation in palliative care. I knew going into residency that I wanted to do palliative care because of experiences with loved ones, even before I picked EM, so sort of went backwards. But I did a rotation in palliative and loved that sort of back and forth from being an EM resident to a palliative care trainee to an EM resident. And then in fellowship, also did several ED, like attending moonlighting shifts per month, trying to keep up my skills. But although it was crazy, it meant, like, especially the month of February, I worked every day of the month as a fellow and an attending. It was busy, but it confirmed for me that I loved, like Bruce said, sort of both roles, and there wasn't a favorite stepchild. So it helped me, because when I was looking for jobs, it was important to find one where I could split my time. And I was looking for a job right sort of in the peak of COVID, which, as you may remember, there were sort of hiring freezes around the entire country. So it was a fun time to try to look for like a split job, let alone any job. But yeah, I think I'm pretty persistent. So did a lot of networking and was able to actually stay in Boston initially. A lot of what others have talked about sort of resonated with me. I worked on a palliative care service, like in the Harvard system. We did consults. We had an ED-based consult team, so can talk offline about that. And then an inpatient unit that not only did end of life, but also just people maybe with curative intent, cancer or other things, but really bad symptoms, they'd come to our like intensive palliative unit, get crazy stuff done, and then go home a few days later and hopefully be cured eventually. But with that, it allowed me to do a lot of ED procedures on the inpatient like palliative side, which was fun. And I agree with what Barry was saying. Medicine people are like afraid, I think, to touch patients. And for us, like I got to do rectal prolapse reductions, thoras, paras, and I billed for all those too. Ultrasound guide IVs, palliative sedation, respiratory failure and high flow, like bread and butter for us in EM. But yeah, medicine colleagues have lots of strengths that I don't, but they were less comfortable with those things. So yeah, for me, like that, those couple of years just out of training really confirmed that I loved doing both. And then when I moved down here this summer, I was able to negotiate a split position as well. I think maybe sort of segueing and tying back to the question about salary too. For me, like in Boston, palliative care versus EM, the pay was about 25% different. So it was a huge pay hit to do full-time palliative care. Because I was splitting my time and I was more EM, that was less of an impact to me, but it was still a pay hit as a new trainee with a bunch of loans. So that was just sort of something I made peace with. When I came here, partly because they were really looking as a system, like at Baylor, to grow palliative care, and I had like a research background and was heading for a grant, I was able to convince them to actually pay me just like a flat EM salary, even though I do palliative care, which I think is kind of unusual, but again, took a lot of negotiating, which our business colleagues do all the time. I hate business negotiating, so I sort of learned from my own mistakes, but I was a little more persistent and it worked out. So now actually, even though I do palliative care, I get paid as an EM provider for both.
To echo that, Jason, actually have a similar setup now where, yes, even though I spend 20% of my time in pal care, I still get paid as a full-time EM attending.
Yeah.
The way they get around it is every time I am on the pal care service, like I said earlier, when I bill, it goes to the EM department. So
yeah, same with me.
it can be done.
Speaking of billing too, shout out to Darren and anyone else on the call. Even if you haven't done a palliative care fellowship, if you're having these conversations in ED, which I agree we all should be doing, it's 100% in our wheelhouse. And I think we're best positioned because like we have the big picture at the bedside of what's going on in the ED. You can bill for those. You don't have to be palliative care trained. And the RVUs are roughly equivalent to a level 4 clinical encounter. And you can tack it on to what'll probably be a level 5 or critical care. So you do one of those per shift. That's like a huge bump in your RVUs to just take better care of patients. And for me, that was like part of how I argued my split positions in both cities. That, you know, yeah, sure, this is better for patients, but the C-suite cares about dollars and patient throughput. And you know, some of the more recent palliative care research that I'm trying to help with now shows that not only is it better for patients when we're involved early in the ED and otherwise, but it actually helps reduce ED lengths of stay and boarding and cost to the system. So I think for people trying to argue a split position, you have more data to support you now than ever, but happy to talk more offline.
Thank you, guys. There are some questions in the chat about ED embedded pal care. I don't know any of us on in this panel are doing that right now, but probably all of us have been interested in it and know people that are doing it. So does anybody want to speak a little bit about ED embedded pal care, what they know about it or their experience with it?
I mean, I'm doing 1 day a week, which is basically like I kind of forced it on my department, who want to have good relationships with the ED and stuff. The places that I know that have a real program going is actually has ended up being much more top-down motivated than bottom-up motivated. Like somebody up there who has pull decided they wanted it and found people to do it rather than the EM doc convincing everybody to let them do it. Yeah, Jason's shaking. Jason's nodding his head, and he came from a place that had a really robust, which is Harvard, had a really robust embedded pal care program, still does. And like I'm part of Northwell, and North Shore hired somebody to do it. Somebody pal care, not me. And so, you know, it's a little bit weird, but it was I guess it was the pal care department that decided they wanted that in the ED, not the, I mean, that it's probably never going to be the ED that decides they want it.
And I can speak to I have someone, and I'm on a grant that's going to be submitted for GW to start an embedded palliative care program. And this one is bottom up, so we'll see how it goes. So it's myself, my attending who is EM Pal Care, my former co-fellow who's EM Pal Care, and another physician. And so, but what I can tell you from someone who's very close to me, who's starting it in an academic center in New Jersey, that it was top down. It wanted it. They pinged Pal. She's a PA, so she was an ERPA, was working with me for many years, and then did Pal. And she has a lot of they don't have the buy-in from the palliative care team. So there's actually more there's more nuances to having an embedded palliative care group in the ER than just, okay, we're going to see the patients, get them started, have those goals of care, maybe discharge them. It's having the buy-in from the palliative team so you're part of the palliative team that you have to then sort of sign out that patient to the palliative team and having them to want to continue that consult. Because there are a lot of nuances and a lot of disagreements about when palliative care should be started, especially from someone who is not EM trained or who has EM experience. Someone who is from an internal medicine background might more or less have some different opinions, especially historically HPM people. Minus the Scripps wonderful publication that sort of like set this like huge explosion of this, the person in New Jersey, the C-suite has basically told them, and so now they're having trouble continuing it because she's now having to have buy-in from the palliative team, which she thought was just going to be automatic.
I can agree with that. I think Jason might be the one who brought this up last year, but so David Wang and I years ago originated this group, and he's a business person. I'm not. He then took over, he's EM. He took over as medical director of the Pal Care program at Scripps and wrote a lot of the articles that have been published about embedded palliative care. And I bring him up because he's always willing to help. He's got an MBA. He knows the stats and the numbers. And if anyone's interested in a ground up approach, just reach out to him. It's David Wang, WANG at Scripps. I have if people will work for free, then my emergency department would love to have embedded palliative care. But the hospital, we're a safety net hospital, they're not really willing to pay for it. And also, as you said, as Alexa said, the palliative care team, they struggle with it's not going to be necessarily more palliative care consults, it'll be more appropriate and earlier palliative care consults. And so getting that message across to maybe an understaffed team can be challenging. But trying to be positive and have solutions. I think there's probably grants, like you need a $50,000 grant, hire a social worker or an APP to sit in the ER for several hours during, a few days and then show your data. But again, I think Jason had good data, and I know David Wang had good data if you're looking for resources to present to your facilities.
Thank you, guys. We are getting close to the end. I wanted to touch on one of the a question that was submitted, and it's also over in the chat, is just about job availability for hospice and for palliative. Can any of you guys speak about what it's like to try and find a job? Are there a lot of jobs out there?
I can speak to that because where I'm working is sort of volatile. So I'm always kind of looking for a job right now because I work remotely for a company called Landmark Health. It's been purchased by Optum. And so I don't know if anybody knows, but Optum has had a lot of variability. They are focusing on palliative care. So for me, that's great. But I'm looking for, so that's why I started picking up IPU jobs. So in the remote world, I think right now, there is a big push to have palliative physicians on remote access parts. So Time Care does it, Landmark does it. I'm trying to think, what is it? Oh, they do kidney work. Oh, Monogram Health does it. So it's value-based medicine. So they have palliative physicians that are there that help to manage patients and keep them from using their insurance, basically, by helping with goals of care and symptom management in the home. Looking for other positions, there's always positions available in the DC metro area. I can think of Kaiser, VHC, and MedStar that are all currently looking for palliative care physicians. So there is always a need for us. The hospices are always looking, as Barry can tell you, that when I applied to hospices out of fellowship, when I didn't know what I was going to do, they loved that I was EM. They loved that I could do things and manage things for them. So I think that background really helps. I think having the ability to talk to different consultants has always been a question. And then people just laugh when they interview, oh, like, how do you talk to different people and manage that? And then I'm like, I just smile. I said, well, I'm an ER doctor. And they just say, oh, okay. So I think as an ER physician doing palliative care, you will always find sort of an option and a role. I think hopefully on April 1st, we will have more Medicare will, not just Medicare Advantage, will be allowed to do more telehealth. So I think that opportunity will expand more as long as we get that passed through, especially for our DSNP populations. But I really work with a Medicare Advantage population. I have to say that, and I wanted to point out to something that Tara had mentioned earlier, which I had a totally different experience, and I want to kind of put it out there, and I'm happy to talk to people offline. Tara had a very supportive spouse. My spouse was not as supportive in the initial, and so a lot of you might have that experience that maybe your significant other is not as supportive because they don't understand. My husband is not in medicine, and he just didn't understand why I wanted to leave EM. He just didn't understand. And he is a trader and does, and he trades energy. So the money aspect to him, it blew his mind. It just blew his mind that I was going to leave a profession that I had a good job and I was making money to something that I was going to work every day of the week and I was going to make less money. So I want to voice that that's out there. He's now very appreciative that I did palliative. He absolutely loves that I do palliative. He thinks it was the best thing for our family and thinks hindsight it was, but there is that hump. And so if people have that experience, you're not alone. So I want to put that out there that my experience when I did that was totally different. It did cause friction in my marriage. We had to plan for my fellowship. It was a financial hit. I still worked EM shifts during my fellowship. And it was hard because I was on call. I was pregnant during fellowship. I have 3 kids and I did EM shifts. So not everyone's experience is rosy. So I'm happy to talk offline with people and be that support that it's going to be okay. And, if you want to do it, it's the best decision I ever made.
Just to add on to, for anyone passionate about research and thinking about trying to dive into the wild world currently of funded research, you may have seen the news headlines. It's a little uncertain these days. I think EM and palliative and doing research is a great mix. Both, like, I personally derive a lot from each of the 3, and I love the balance. And I start to get burned out from one, and then I rotate, back to the other clinically or otherwise. So that's been great. I'd love to talk about that offline if you're interested. But also, like others have said, I think, coming from EM, we're used to adapting to all kinds of chaos and uncertainty. I think having 2 clinical skill sets makes you even more sort of flexible and able to adapt. And then if you do research and sometimes get lucky like I did and get an NIH grant, or you're in between grants, like you can again flex and still have kids and support a family or your life or things that are important to you with that trifecta. A little bit of extra work and chaos, but happy to talk more offline.
Thank you so much. Yeah, we are down to 2 minutes, and I want to echo what Jessica said. If you guys want to have more of these conversations, the Palliative Committee is really small. We meet monthly, I think the 4th Thursday of every month via Zoom, and we talk about this stuff all the time. But the last thing, because I just wanted to throw that out there before you guys start jumping off, because I'm sure many of you have to leave right now. But if you have a minute to stay on, I wanted to ask our panelists, can anybody talk about jobs if you don't get board certified, if you don't do a fellowship? Does anybody have any insight into what's available for an ER doctor if they want to start incorporating some practice? Maybe it's not full-time, but if they want to start doing some hospice work, is that an option?
You don't get board certified in EM or in hospice? Sorry, which?
And
Sorry, there Not in hospice and palliative medicine. Yeah, if you don't do a fellowship and get board certified, you are a practicing ER doctor. What jobs might be available for you?
Rurally, anything.
Yeah.
I mean, I think you can
At an
get,
academic center, nothing.
I started off not being board certified for the first 2 years and home hospice. I think you could still do it. I think it's coming less and less because there's definitely more people being certified and the specialties growing. And so I think it's getting harder. Like they always ask me, are you board? Whenever I look at an opportunity, they're always asking me,
Yeah.
are you certified? Are you board certified? So I think it's becoming a little less yeah.
And I have to say, even from and I don't know if Bruce and Melanie had this, but sorry, I'm a little sick, but when I was not the boards are now every year, but I was the year that it was I was the last year that it was every other year. So like I had to wait a full year before I was able to take my boards. And people were like, are you board certified? And I'd be like, no. And they'd be like, well, then you can't have this job. And I'm like, but I'm PAL trained. And it's not that I haven't passed my boards. It's that I haven't had the opportunity to sit my boards. That is changing now. So, but I would say I think it was easier 5-10 years ago, probably, right, Barry, that it was easier to get those jobs. If you had you could show you've done it, you've showed you've had some clinical work, but now it's a lot harder. And being board certified is really sort of the way to go. And now that it's yearly, I think it's going to be more and more the norm.
And I tell
I
you,
think
we shouldn't underestimate our worth because people are always willing to pay you very little to do our jobs. And I think as doctors and people that really believe in our profession, which I really do, and I've been very clear with people that I work for, if you're not willing to pay me what I'm worth, that's fine. Then I won't take the job. You can go find someone else. It's just not okay when they're like, hey, will you do this for $1,000 a month? I'm like, why would I do this for $1,000 a month? Like, why would I answer my phone all day for you for $1,000? Like, really?
right.
It's just
Right.
not, it's not okay. And I'm very clear. I've just had to have that a talk. I'm like, I'm okay. I'm okay with you not hiring me. Don't worry about it. I'll find something else to do with my life or my time.
I also wanted to mention that in the outpatient hospice field, that career is still wide open for people who have not done fellowships. There is a certificate program that you can take, an educational one, and get the certification. And I really think that hospice agencies are still looking for people.
Yes. But they're willing to really underpay you. I'm just
Yeah.
like,
No, those are not necessarily the greatest jobs.
right.
And
Because
then-
they're going to find someone to do this for really cheap. And I'm like, go ahead, enjoy.
And I have to say, there is a mid-career fellowship program out of Colorado that does where you do a master's, and then after the master's, you can apply for their fellowship, but you have to be accepted into that part, and you do it in your home institution. I looked at that heavily, but because I had to pay up front, it was like, it just didn't make sense, because even if I finished the master's, it didn't mean that 100% I would get to do finish the fellowship. And to me, it wasn't worth the financial risk. I would rather just take the hit and do the year, because in the end, it was going to cost the same. So just to put that out there, if you guys, it's the University of Colorado. But I think that everybody's right. Like, if you want to do hospice for cheap, they'll do it, because if they need it, they'll have you. But for inpatient palliative, they want a board certified physician. And the reasons I'm actually going back to the IPU is because for telemedicine positions, they're actually wanting my logs for patients that I've seen. And since I don't clinically really see palliative patients, I do processes for palliative. That's why I'm going back to have those logs. And also, I miss the patient care. I mean, I like going to the ER, but it gives me so much anxiety sometimes that I would rather go back and talk to my patients at the end of life and have a nice conversation with them. And it's at the IPU that tried to hire me the first time. And so when I asked them, they were very accepting of me coming back at any cost for them for a weekend.
Thank you guys so much. I want to thank everyone who attended this webinar, all the questions that you guys submitted, and thank you so much to our panelists. Definitely couldn't have done this without you. I'm so happy to see there's so much interest in palliative care. Again, just another plug, please consider joining our committee. The meetings are usually really small, very opening, very welcoming and laid back feel.